Good evening, everybody here. After tea break, I think it's a good, nice to sleep again. But during the debate, I think you'll all wake up. So today's debate is about whether there should be a very good diabetes control or we should have a cardio-renal protection. This is one of the most important hot topic all over the world. There are some set of people who say that sugar control is the and the everything of diabetes control, not bothered about what happens later on, because everything micro or macrovascular complication is due to sugar itself. And you control the sugar, everything will be all right. Another group, of course, is about cardio-renal protection. The reason is, all of us know that the death is due to cardio-renal disease in diabetes. As they say, nobody dies of sugar, but they die of cardio-renal problem. So to decrease the mortality, morbidity, and so on, we are going to have a discussion. Dr. Arjun and Dr. Himamshu are going to battle it out, and at the end of the day, if I don't get confused, I will give you some confusing signals. Thank you.
Thank you, sir. Thank you. So, as sir rightly told, I am fighting for glycemic control. Today, I am the lawyer. I will not be devil's advocate. I will be devil's advocate for people who are supporting cardio-renal protection. So now, there is no smoke without fire. There is a saying that there is no smoke without fire. So, what is smoke, what is fuel, and what is fire? That is what we think about as of now when we consider chronic complications of diabetes. So, micro and macrovascular complication, if we consider it as smoke, hyperglycemia is fire, fuel for the fire, and inflammation and metabolic dysfunction is the fire. So, if you consider that, should we take out the fuel or should we just look at the smoke and take out the smoke with the exhaust fan? That we have to think. So now, most of us are familiar with the complication of diabetes chart. Hyperglycemia is the driver for all the pathways for complications of diabetes, be it polyol pathway, be it advanced glycosylation end product pathway, be it protein kinase C pathway or hexosamine pathway. So hyperglycemia is the cause, it is the pathophysiological driver of the disease, and it is the pathophysiological driver of complications. Now, when you talk about theory, you always we ask about proof. So is there any proof? Of course there are. So there is something called metabolic memory, the phenomenon where early glycemic exposure influences the risk of complications later. So if a diabetic person living with diabetes, if his glycemic control is very good in the beginning stage of the disease, later stages he will have lesser complication. This is also called as legacy effect as per DCCT and DCCT EDIC trial and UKPDS. So these are the two terms which we are familiar with. So if you consider here, if you notice the DCCT trial shows that the conventional treatment when they have for first 10 years versus intensive control, the complication even after 16, 17 years, the complications are more when the conventional treatment is given, and the intensive treatment group has lesser complication. So that tells you the importance of glycemic control. If you look at UKPDS also, the outcomes are similar. If you have early good glycemic control, the complications are better, results are better at a later stage. So what is the core pathophysiology here? Hyperglycemia leads to metabolic epigenetic modifications like DNA methylation and histone modifications, which will ultimately lead to metabolic programming, which will increase the complications of diabetes in long run. So here also the driver is glucose. Increased glucose levels drives all these changes. Now, long-term data, as I told, if you go to all our legacy trials, DCCT follow-up, which is EDIC, and UKPDS and UKPDS follow-up, they were all very long-term trials where observation was for at least 5 years. Some trials are followed up to 30 years. Now, when you talk about cardio-renal protection, we always talk about SGLT2 inhibitors or GLP-1 analogs nowadays. But those trials hardly ran for 2 to 4 years because these were mainly pharma run, and they were all only strengthened to do with minimal cost measure. So they were run only for 2 to 4 years. So now if you see all the trials, DCCT, everything, it's almost like above 5 years, up to 30 years, the trials have run. When you go to SGLT2 inhibitors, if you see, hardly 2 to 4 years or maybe 5 years max. So these are the results what they have got from basic minimum requirement, whatever has to be has to be shown to the FDA or any regulatory body that has been shown. Now, if you consider GLP-1 trials, those are also only for maximum 5.5 years. So, in comparison, our glycemic control trials were actually run by not by companies. Those were run by either NHS or by the US Army Veterans Department. So those had no financial interest, they had longer follow-up. On the other hand, GLP-1 SGLT trials are all run by the industry. So many cardiorenal trials lasted less than 3 years, whereas DCCT, UKPDS and VADT, they showed that the glycemic control in the initial phase had a very long-term benefits. Probably in next 20 years, we may get good outcomes if any follow-up studies have been are being done for SGLT2 or GLP-1 analogs. But as of now, we don't have a long-term data. So these short-term trials are always better for drug marketing. But if you are managing patients' disease over decades, glucose control is still the long game. So we should not miss the forest for the trees. Retinopathy, peripheral neuropathy, and diabetic foot, also infections and erectile dysfunctions. These are all known complications of diabetes with poor glycemic control. And your SGLT2 and GLP-1 analogs don't do anything for this. And in fact, SGLT2 may cause some candidal infections or even UTI. All the trials don't strongly support that. But there may be, we are clinically seeing lots of other complications which are related to SGLT2 inhibitors. So if you focus only on heart and kidney endpoints, you may fail to treat the whole patient. So now coming to GLP-1 analogs and retinopathy. So this was one article published in 2023 where GLP-1 analog receptor agonists and HbA1c, good for heart but less so for eyes. So what did they find out? It was a meta-analysis for 6 CVOT trials. So they found out that retinopathy relative risk was okay, as in 1 for the other arm versus the GLP-1 class, but however parenteral semaglutide had a RR of 1.73. So and it was clinically significant. So out of 6 CVOT trials, retinopathy relative risk was 1 for overall, but for parenteral sema it was 1.73. So here you can see the control arm had a better outcome with respect to retinopathy. You can see the SUSTAIN 6 which had 1.72 relative risk for retinopathy, which is with the semaglutide. Now coming to SGLT2 inhibitors and ocular events, there are not many events, not much evidence regarding that. Most of the trials are neutral. But is it giving any benefit? No. So what I want to say here is, even if it is not causing harm, it is not giving us any benefit, additional benefit when it comes to retinopathy. Similar study, one more long study, as in it was meta-analysis which was covering 40 studies, which had 104,000 patients, and 84% of them had type 2 diabetes, and eye outcomes were neutral. So now one more newer complication has come up with GLP-1 analog, which is non-arteritic ischemic optic neuropathy. So if you can see that the relative risk of, sorry for the pointer, yes. Yeah. So the relative risk is quite high for people who are having type 2 diabetes who are on semaglutide, whereas people who are not having diabetes who are overweight, for them also, people who have received semaglutide, the risk of non-arteritic ischemic optic neuropathy is more. So the odds ratio are here. So among 6,827 patients who were screened, 710 patients had type 2 diabetes. Out of them, 194 were prescribed with semaglutide. So what was the cumulative incidence of non-arteritic ischemic optic neuropathy for semaglutide? and it was around 8.9%, whereas for non-GLP-1 and non-GLP drugs, it was 1.8%. Clearly, there is increased risk of non-arteritic ischemic neuropathy with GLP-1 analogs. So should we ignore? See, cardiorenal saviors such as GLP-1 analog and SGLT2 may not harm with respect to retinopathy. There may be more data which is required in future, but even if the trials are neutral, you always have to take it with a pinch of salt. They may not be beneficial either. They may not be harmful, they may not be beneficial, they may be neutral. But when you consider glycemic control, they are definitely beneficial according to our legacy trials. So do we just put an exhaust fan for our smoke, or should we take out the fuel itself, that is hyperglycemia? Now coming to lower limb amputation, when earlier canagliflozin came out, that was a big FDA warning was there regarding canagliflozin about lower limb amputation. Later, all the SGLT2 inhibitors, when they analyzed, there was not significantly increase with all the SGLT2 inhibitors, but it was boxed towards canagliflozin, saying that no, only it is drug specific and not class specific side effect. If you see, there are 12 RCTs done on SGLT2 inhibitor, which at least out of which at least 7 had one event at least, and there were 18 observational studies with relative risk of 1.28, which was not significant. But however, canagliflozin with 2 RCTs had higher risk of lower limb amputation, which was clinically significant. So this is the same article which I mentioned, which shows that SGLT2 inhibitors had higher risk of, especially canagliflozin had higher risk of lower limb amputation. So another study published recently also showed the same thing, 1.2 odds ratio for all the SGLT2 inhibitors versus canagliflozin, which had 1.6. So it had a relatively narrow confidence interval, so you can confidently say that it may increase the, it will increase the risk of lower limb amputation. So now, one more thing which always, we see clinically is behavioral empowerment. That is, when you show a patient about his glycemic parameters, either SMBG reading or CGMS reading, they are always motivated to follow lifestyle, follow medications, and follow diet. So which can be used as an educational tool. We had a CGM talk just maybe around half an hour back, which also highlighted on that. The things which CGM tells can be used as an educational tool. So if the patient himself or herself is motivated, then glycemic control becomes easier. So this is one more trial which showed around 150 each on CGM and follow-up CGM, in which data were revealed. Patients who had CGM had a better HbA1c with 0.439 difference in HbA1c. So glucose control offers immediate feedback to the patients through either CGM or SMBG, and it helps in reinforcing lifestyle changes which include exercise and diet, and in turn exercise and diet will improve insulin sensitivity, blood pressure, lipid profile and weight, which will lead to better complication outcome. You don't have to look into complication as such, you just show the patients the number of glucose readings, and then it will motivate. At least part of our patients will get motivated because of the numbers. So now, clinicians may feel sometimes when you start GLP-1 analog or SGLT2 inhibitor that we are doing enough, but it is not enough. You should always look into glycemic control also. So it should not be cardiorenal comfort at the cost of glycemic neglect. So now, another thing which is very relevant to our part of the country, or even entire India, I should say, that most of our drugs which are involved in glycemic control are quite cheap when you compare with GLP-1 analogs. Earlier, even the SGLT2 inhibitors were costlier, and now they are relatively better. There is a flood of them, SGLT2 inhibitors recently only, in the form of empagliflozin. But whatever said and done, GLP-1 analogs are still costly, and when you consider hospital admissions, sepsis and amputation, probably controlling glycemia instead of focusing totally on cardiorenal protection is important, because it is also cost effective. If the glycemic control is better throughout, there is less likely chance of patient developing any complication, and the lesser chance of complication will reduce the cost of healthcare. So So this is one more thing which I wanted to show. There is something called number needed to treat. So how many patients should be treated for to prevent one complication? As in, if you let's take EMPIRIC trial, you have to treat 63 patients to prevent one MACE. So these are the numbers. If you look at it, higher the numbers, higher the cost of the treatment for the entire population. So if you look at all the NNTs, most of them are between 40 to 90. Whereas if you look into the traditional numbers with our traditional trials, as in legacy trials, although the numbers were not calculated because those numbers were not being calculated at that time when the trials were published. But if you take the numbers now and recalculate it, so the better control of glycemia always, you just have to treat 2 to 3 patients to achieve the target in terms of retinopathy in type 1 diabetes as per DCCT trial. When DCCT, EDIC trial, if you consider any major complication can be prevented if you treat 3 to 10 patients. You don't have to treat 60 to 70 patients to get one better result. When you go to UKPDS, it is around 19 to 29. When you go for UKPDS 80, which is if you are targeting only CV and all-cause mortality, it is around 10 to 20. If you consider VADT, you have to treat around 29, 15 to 25, depending on what complications you are looking into. So if you consider these numbers versus these numbers, definitely glycemic control numbers, you have to treat lesser number of patients to prevent complication. So the questions remain, HbA1c of 12 with normal EGFR, are cardiorenal protective agents enough, or do we need insulin along with the drugs for glycemic control? Should we not address main pathologic driver, which is hyperglycemia? So we should always, I'm not saying that cardiorenal protection is not important, but glycemic control is also important. And when it comes to diabetic management, ABC should be A1C, blood glucose, and complication. So to summarize, DCCT, EDIC, UKPDS, VADT, all are legacy trials. They were decade-long almost with good results. And most of our SGLT2 inhibitors and GLP-1 analog trials, they ran for 2 to 4 years. And what happens in 10 to 20 years, we don't know yet. And when you talk about cardiorenal protection, is it for all? Because most of the times the results are very modest. So is it for all? That question comes. And suppose if the patient is having anemia or low EGFR or hypotension or any frailty, or if they have polypharmacy, these drugs may not be actually indicated because they may develop hypotension if they have, let's say, autonomic neuropathy. If they have very low EGFR, many of the drugs are contraindicated. If they have frailty, there may be higher risk of fall with SGLT2 inhibitors. So there are many contraindications. You always have to balance between the cardiorenal protection versus adverse effect. And glycemic control through diet, on the other hand, is diet, lifestyle, and safe titration of agent. It is always achievable in most of the patients, and in real world it is easier to safely manage glucose than to optimize complex organ protection regimens. And also cardiorenal drugs, they always manage consequence of the disease, not the cause, which is hyperglycemia. And addressing glucose changes always takes into picture the initial part of the disease, which is hyperglycemia, and the whole disease trajectory will change. If you control the glycemic part in the beginning, the whole disease trajectory and morbidity and mortality complications will also change because the trajectory will be a flat trajectory. On the other hand, if you are targeting complications, it is almost like you have reached the complications already. And for every diabetic patient, regardless of age, they need glucose control. And cardiorenal drugs are only indicated in a subset of patients. For primary prevention, yes, probably. Last year I had a debate where I had to talk against SGLT2 inhibitors. This year also I'm talking against cardiorenal metabolic complications. So basically there may be a role in primary prevention, but as of now it is not SGLT2 for all or GLP analog for all. We always look into complication and then start the drugs. So you must give control of HbA1c for all the patient. You should not be giving everyone SGLT2 or GLP-1 analog or both. So thank you. I think it's time up.
Thank you, Himanshu. Himanshu turned out to be a sugar buster. So he believes in busting the sugar, and he has given a lot of reasons for that. But then he is thinking of extinguishing the fire when the house is on fire and leave the house alone. House will take care of itself when the fire is gone. I ask Dr. Arjun to take over and start his debate.